at present, few cancer programs have a systematic process in place to identify patients in need and to develop a plan to meet their cost of care. What we find is that in most hospital settings, and there's starting to be a shift where this isn't happening anymore, but there's fragmented care going on in the system, so different departments have different responsibilities in regards to the financial advocacy, financial navigation process. While if you're using the old system where it's different silos doing different parts of this, it doesn't help the patient, and it will not help you as a provider in regards to capturing revenue and decreasing out-of-pocket responsibilities for patients. So let me give you an example of this, but this is what happened in our facility. So I had been pleading and begging with our hospital system saying we need to have a financial navigator in our setting. It is the #1 stressor. I was there employed as a social worker addressing all of the emotional and practical needs of our patients, and over and over and over again I was dealing with financial distress. And so I was going to administration and saying we need somebody here that can do this. And there was no intention for it to be me. I enjoyed working with end-of-life issues and helping people through the counseling process, the mental health process, but just needed to deal with this because it became a necessity. So finally I went to management and said, okay, let me do a pilot. I'll promise to save you guys $70,000 in 6 months if you just let me do some special financial navigation services for our oncology patients. They said, fine. 2 weeks into that, I received a phone call from a manager in our billing department who said, hey, Dan, I've misplaced the phone number to the oncology director. Can you give me her number? And I go, sure, here it is. And he goes, I just need to get her permission to do an adjustment on an account of $100,000. I perk up and go, can you tell me a little bit more about this? And he goes, sure. So I'll send over the files, I'll send over her case, and so you can take a look at it. And so, yeah, I get her chart, and I open up the chart. Well, this patient was receiving off-label treatment. I see there's a note in the chart that patient access had identified that this was off-label. I also see that the nurse had filled out a Genentech patient assistance program. So to try to get assistance on this, so that was all in there. I saw that there was a letter from Genentech saying the patient has been approved for assistance, and then it stopped there. So when I'm looking into this, I contacted pharmacy, and were you aware that this was off-label and that possibly we can get this product replaced? The answer was no. I contacted patient access. They said, well, all we were worried about was if this is off-label or if it's indicated for the disease. That's all that they were concerned about. Billing department had no idea that the nurse had enrolled the patient. I went to the nurse and said, okay, so you got the patient into the program, then what? She goes, what do you mean, then what? I was done. So nobody was requesting the drug from the pharmaceutical company. Nobody was communicating with anybody within the system. So guess what? Within the second week of my pilot, I reached my $70,000 in savings, didn't I? Right? It didn't take long at all. But it made it really clear for me, oh my goodness, we need to do better communication here within the different systems within the hospital. What had happened to the patient? The patient actually had received a letter from Medicare stating, we're not going to cover this. The patient was in distress, and we didn't even know about it until I was able to go and speak with the patient and explain, here's what we're going to do to fix this problem for you. So bridging these silos, it is the #1 issue, I think, that financial navigators need to be doing. And who is the best person that can address all of these different issues with the different departments? Well, in my opinion, it's the financial navigator or the financial advocate. They can speak the languages of all of these different departments. They all have different tasks, and they all have different goals that they're trying to accomplish, and the financial navigator can put those pieces together for the patient and also for, obviously, the provider. If the financial navigator does this well, right, if they're connecting the dots between pharmacy and patient access and the verification team and billing and the patient and the multidisciplinary team, it is my argument here that there's several things that's going to improve. Obviously, you're going to have improved access to care. It's going to happen faster. It's going to be smoother for the patient, and it's going to move along a lot faster. You're going to have a better patient experience. If you imagine yourself, if you are at an airport, at least this happens to me because time is important for me, and I'm at the airport and I'm going, okay, I got to be at my certain area at a certain time, and if there's really bad signage, my stress level goes up. I don't know where I need to go. I'm in a new environment. I have no idea where I need to go, right? Well, it's the same thing, same scenario here for patients. They're in a brand new environment. They are feeling overwhelmed. And unfortunately, I've seen this all too often, that a standard answer to the patient, if the patient starts asking questions about, well, what is my out-of-pocket responsibility going to be? A standard answer, unfortunately, is often, call your insurance company and find out. And it doesn't help de-escalate the anxiety that the patient is experiencing. And then I think it also it stabilizes your financial needs at the hospital, right? So you have less out-of-pocket, you have less charity, less bad debt that happens if this stuff is done well. Let's start talking about working specifically with the patient and communicating with the patient. And the first thing that at least I think about when I'm working with a patient is the timing of all of this. When do you go to the patient and start addressing some of these issues? And somebody in our social work department said, I don't want you to see the patient on the day of consult. And they said, because the patient is already overwhelmed. They're already seeing a whole bunch of patients. We don't want to add somebody else, to this chaos that the patient is experiencing on the day of consult. Well, I argued back and said, I'm going to have to disagree with that. Because when you look at the statistics, if you look at research, what patients are experiencing, well, what is it? I know on the day of consult, they're thinking about their diagnosis, right? But they're also, the number one stressor of oncology patients is financial. And it quickly, as soon as that diagnosis happens, it quickly moves over to how can I do this? What is my out-of-pocket responsibility going to be? Do I have access to care? Is this going to cost me $50,000? I get that question or that statement made to me very often. Is this going to cost me $20,000? When in fact they have an insurance policy where the max out-of-pocket is $3,000. They just don't understand the insurance terminology. And so we did adopt the process where we see the patient on the day of consult when they come in. And one of the benefits of this is it gives me an opportunity. The physician is meeting or has already met with the patient. I'm getting firsthand knowledge about this patient immediately from the physician. My first stop is talking with the medical oncologist or the radiation oncologist. What's going on here? What's the treatment plan? What is the next 2 months going to look like? What's the next 6 months going to look like? Because it does affect the way I'm going to navigate this patient from a financial standpoint. We also, when we think about timing here, I had a patient come in. He was in his 50s. He was married. I looked at the insurance, and immediately I was not concerned, right? I think he had like $1,000 max out of pocket for the year, and he had already met most of it, so he was near 100% coverage for his care. But I went and saw him anyway, because I looked at his diagnosis, and unfortunately for this gentleman, he was diagnosed with a GBM. I looked at his insurance, and I see, oh, he's the one that's carrying the insurance, right? He's employed, he has insurance through his employer. What am I thinking about as a financial navigator? I'm thinking about the immediate needs, and I'm thinking about long-term care needs for this patient, right? And so what's going to happen to this gentleman with a GBM? Odds are extremely high that he's not going to be able to maintain employment. He's going to go on short-term disability benefits. He's going to go through his FMLA benefits or coverage. And then what's going to happen? He's probably going to be terminated from his position. That happens probably 90% of the time. And then he's going to be offered COBRA. and then they've already had a decrease in income, you know, I could see financial distress coming down the road, not right now, but 3 to 6 months down the road. And the approach that I take when I start working with patients is I would much, much rather solve a problem than solve a crisis, right? It's so much easier. And so I made a deliberate attempt to go and meet with them, sat down with them, talked to them about, hey, let's apply for Social Security disability. Let's have a conversation about that. Let's talk about your FMLA. Let's find out how long your short-term disability benefits are going to last you. And do you have long-term disability benefits? Well, we went through this whole process. Once again, did I need to see that patient that day because of access to care problems? No. But there was going to be a problem down the road. Because of the timing, because it was addressed very early on, it helped de-escalate a problem that was brewing. And this scenario plays itself out over and over and over again in the oncology setting. The other thing we need to think about is empathy. I never, ever want to be put in a position where I'm thinking about the financial benefit to the hospital above the financial or what's in the best interest of the patient, right? Because I can go home and save $70,000 very easily, but the patient is maybe not as good off. And that's not, I want to go home and sleep. And that is a very important principle to keep in mind when you're thinking about communicating with the patient. And so when I go into a room, I force myself, and it becomes quite natural, but I concentrate on what is best for you, right? And then I think about the financial issues secondary. Mental health skills is, in my opinion, very important to have in this role because you're dealing with some really raw emotions when you're working with these patients. They're overwhelmed, they're scared. And when you think about, you know, if you want to take the example of Maslow hierarchy of needs, right? The base of that hierarchy of needs is the physiological, so, you know, getting food, getting clothing, your physical needs, are they all being taken care of? The second level up is security, right? And when you think about what that patient is experiencing at that moment, both of those base levels are being threatened. Right? Their physiological, their medical needs are being threatened. And when you start talking about security, there's a lot of issues in security, but one of them is financial. If I don't have money, how am I going to be able to pay for things? How can I do transportation? How can I get food? How can I afford my medications? The list goes on and on and on. So being cognizant of the fact when you're meeting with patients that, and being able to communicate that to the patients is very important so that the patient will start trusting you. I have said often that if I don't get the patient to trust me within the first minute of my interaction, my navigation process becomes a lot more difficult. I am showing a level of expertise to the patient so that they can feed me more information, once again, to help me navigate those patients appropriately from a financial standpoint. So education. The way I like to look at this is, when I have a patient that comes in and let's say they have a large out-of-pocket responsibility for their care. They have non-small cell lung cancer and they need chemotherapy and they have a $5,000 out-of-pocket responsibility for that care. Well, you can get them into a copay assistance program to help cover that for them. Or if they come in with no insurance, I can get them into a patient assistance program to get free drug for them. Those are all practical things that I can do for that patient to help them with and I'm doing most of that work. There's another way of looking at this and saying, well, if I educate the patient, and if I educate the patient on picking the appropriate plans for them, the appropriate insurance plans for them, they'd be much better off. Kind of like in the example here of Medi-Cal. You know, there's a process you go through. I'd much rather have them in the BCCTP program, right? Because it's 100% coverage for your care, it's free. Well, what if you could do that with Medicare plans? On average, 50% of your patient population is going to be on Medicare. And 33% of Medicare beneficiaries are on a Medicare Advantage plan. And you've heard over and over again here today that Medicare Advantage plans have significant out-of-pocket responsibilities for their care. Well, what if you could sit down with those patients and say, you know, during open enrollment period, here's what you can elect. and you can switch over from a $5,000 out-of-pocket responsibility to 100% coverage for your care if you select the right policy. Now, what have I done? I've educated the patient. They've enrolled themselves into a new policy. And do I need to see them again? Most likely not, right? Because there's going to be no more access to care problems because they have 100% coverage for their care. And in the world of Medicare, sorry, that thing got kind of cut off there. This is very often what happens. I don't know if you have family members, hey, you work in the medical field, can you help me pick my Medicare plan, right? And you might be scratching your head going, I'm not quite sure how to do that. And unfortunately, so many of our patients have no clue about how to pick the 60 to 80 different options that are available to them when they're new to Medicare. I provide seminars to our patients on Medicare. And so we have 70 people usually that come at each time. And I go through a 2-hour process of explaining all of the benefits of Medicare, how it's structured, what are all of your options, so they're better educated on the plans that are available for them. I also spend a lot of time in explaining health insurance terminology, health insurance options. So if a patient is offered COBRA, in the past, boy, you were kind of stuck. Either you do COBRA or you have no other availability for access to care or insurance. Now you have the ACA in place, and so if you are offered COBRA, that's a life-changing event, and you can actually enroll into an ACA policy. And for some people, being in an ACA policy would be much better than sticking with your COBRA policy, and for some patients, staying with your COBRA policy would be much better than being in an ACA policy. So I spend a lot of time educating patients on here are all of your options, what would you like to choose? Who does the paperwork? Well, in my social work training, I was trained, don't ever do something that the patient or the person can do themselves, right? And so I got a lot of kickback from our social work department going, why are you filling out those forms for those patients? They can do that themselves. Well, by experience, if I let the patients do this on their own, I would probably get 10% of those forms back. And when we're talking about, literally talking about hundreds of thousands of dollars in benefit to the hospital, I'm sorry, I'm going to do the paperwork for the patient. And is that good customer care? It is. This paperwork, there's 1,500 different pharmaceutical companies out there, and they all have different processes and different applications for their programs. And you ask a patient who's never done this stuff before to do it, it just doesn't work well. And so this stuff gets complicated for me sometimes, going, oh, what form do I use now? And so I do the paperwork. And I just think that is a win-win scenario. It helps the patient and it helps the provider. And involvement of family and caregivers. When I'm seeing the patient another reason why I see the patient on the day of consult, and that's because family tends to be there at that appointment, right? And so if I have a patient that comes in with Medicare only, so they have a 20% responsibility for their care, in Michigan, we can purchase a Medigap policy whenever we want to and enroll and get 100% coverage for that patient. Well, it does cost something, either $40 a month or $122 a month, depending on which plan you pick. And I can't tell you how often, when I've walked into a room and I've explained this, we can get you 100% coverage for your care, but it will cost you either $40 or $122 a month, and the patient goes, I'm on a fixed income, I can't afford it. The son says, Mom, I'll pay that for you. I want you to have 100% coverage for your care. I don't want you to worry about this. That happens over and over and over and over again. And so involving family and caregivers into the financial navigation process, I think, is very beneficial. Communicating with a multidisciplinary team. So when I am working with the physician, it is extremely rare that I will send that doctor either an email or write a note and put it on his desk. Very, very rare. Why is that? I want the one-on-one interaction with the physician because I am feeding the doctor information. Hey, we got an access to care problem here. Here's what I think I can do to fix this problem. But I'm also getting information from the physician going, you know what, there is a strong sense of urgency here. What can you do to make this happen as fast as possible? Or there is not a strong sense of urgency. That gives me more time to do other things that I might be able to do for this patient. So, physicians are concerned about access to care, and I am going there to try to accomplish that goal for the physician. RNs, and I'm generalizing here, okay, but RNs, they start getting concerned about the care for the patient, right? And so if I have a nurse that comes to me, or I'm going to a nurse, I'm thinking about those issues so that their concerns are being met as well. And why is that important? Because I want information. The more information I get from the whole multidisciplinary team about this patient, the better I am at navigating these patients through very complex systems. Social work department, have you ever met a social worker that's not overwhelmed? I don't think so, right? Certainly in the medical setting. And if I'm going to the social worker who's just so frustrated with dealing with all of these financial issues, say, let me take that off your plate. I can handle this. Let me navigate these financial implications here so you can focus in on what you've been trained to do, which is not the financial part. Verification and prior authorization department. Boy, am I wanting to be close to them, right? Because they can feed me information. If they can, like, I think it was Clara, somebody mentioned, yeah, it was you, Clara. Why seek this information twice? If the verification department already knows that there's a $4,000 out-of-pocket responsibility, I want that information, and I want it as fast as possible so that I can start putting the tools and the systems in place to help this patient. Then, so I'm getting all of this information from these different departments. But the other thing that I do is I'll go back to them and say, hey, we just fixed this problem. Hey, we just got some free drug for this patient. Hey, this patient now is fully insured. We don't need to worry about access to care problems. And why do I do that? And it kind of sounds like tooting my own horn, but that's not the purpose behind it. The purpose behind it is for the team to understand what I do so that they keep referring more and more patients through and have them coming my way. And the other thing that happens, and this kind of happened accidentally, I didn't do this on purpose at all, but the team starts pumping up the benefits of this program. Hey, you really need to meet with Dan, or my colleague, Shauna. You need to meet with Shauna because they can do things that are quite amazing. They can squeeze money out of a stone, as one doctor uses that phrase all of the time. And so now, what happens if the physician is saying this to the patient, and I walk into the room, the trust level is pretty high already, which is very, very important for me. All right. Communication within the healthcare system, that tends to be the most problematic part of this whole process, strangely enough. And the reason why it's problematic is because you're changing culture. It is said over and over again in this conference here that the financial advocacy and the financial navigation process in the oncology setting is very different than in your typical hospital financial counseling programs. And changing that culture and changing that way of thinking, now I'm going to generalize here, but many times in the financial counseling services of the hospital, their tools are, here's a Medicaid application, here's a charity application. And we in the oncology have many more tools up our sleeves to help those patients with patient assistance programs and copay assistance programs, the ACA, and helping people get better Medicare plans, those type of things. And so changing that way of thinking has been very, very difficult and tends to be very difficult. Communicating with the pharmacy, I think is very important that you have a strong contact in your pharmacy departments, because when the shipment comes in from the pharmaceutical companies, that needs to be documented well, right? So the patient doesn't get a bill for drugs that you've gotten for free from the pharmaceutical company. Monthly reconciliation meetings, making sure that there's no bills going out to the patients that have received pharmaceutical assistance. The billing department, what I have found to be very beneficial is to have one or two key individuals that I can communicate with, specifically when it relates to copay assistance foundations, because the billing process for that can get quite complicated. And rather than, in a hospital system, if they have 50 billers and having all of them kind of touch on it here and there, it's better to have one or two people do it so they become experts as well. And then patient access, I've already discussed that the role is very different. In the hospital setting, the financial counselors are going to do a charity app, a Medicaid app. A financial navigator is going to go, you have stage 4 colon cancer. You're probably going to be needing Avastin. You're probably going to be needing Xeloda. Xeloda is a Part B covered drug. I want to make sure that you have good Part B coverage if you have Medicare. Those type of things are going through my mind as I'm navigating these patients through this process. So what are some of my recommendations here? Certainly I strongly push for having the financial advocate or navigator on your revenue cycle team if you have one. When we did that within our system, there was a whole bunch of aha moments that we had when we started communicating the different needs of the revenue cycle. Quarterly reporting to the leadership team. This has been discussed several times as well. Being able to show the benefit that you're providing on an ongoing basis to administration is very important. So they know that the program is providing its worth as well as continuing to support the program. I also strongly advocate to have a financial navigator as a primary role. Right? So many settings, it's part of somebody's job. So it might be part of somebody's nurse's job or a social work role. And usually what happens then is that it takes on a secondary status rather than paying full attention to this very, very important role. This is where my bias comes into place, but you've heard over and over again today that these systems are very complex. And things are changing on an ongoing basis. Programs are changing on an ongoing basis. And so, going through a training program to get a knowledge of all of these programs, I have found very useful. But that's my bias, obviously. Also, finding the right person for this role is key for the success of the program. So I'm going to steal a comment or a statement from Leon Neeson, is that his name? From Taken. I have skills, a certain set of skills, right? The financial navigator has a certain set of skills that is quite unique. And hiring the right person, hiring a person that doesn't necessarily take no for an answer the first time, right? Having a financial navigator that's willing to go and communicate to a whole bunch of things. Being willing to go on a treasure hunt, because that's really what it becomes in many circumstances of going, you know what, I'm going to go through there's 9 different copay assistance foundations out there, and you got to match the diagnosis and the treatment. So it's a treasure hunt, somebody who enjoys that kind of thing. And strong passion for the role as well.